Why, hello there. So, today we're going to be talking about endocrine disorders. Endocrine, HPA axis, kind of peeked at this already. Hypothalamus is the control center. It's going to sense levels if they're low and release a releasing hormone. Once that releasing hormone is sent out, it passes directly into the pituitary gland. Okay? This does not enter bloodstream, so we can't measure this clinically. Once in the pituitary, it acts on cells there, and we release some hormone. Okay, so in this scenario here, corticotropin releasing hormone is released, which acts on the anterior pituitary to release adrenocorticotropic hormone, or ACTH, which acts on the adrenal cortex, which causes the release of cortisol. Okay, as these levels increase, we create negative feedback. We turn the systems off. Okay? So it regulates itself, as it should. All right, a little refresher here also. So what can pass through cell membranes? Basically, anything that's really small, nonpolar, or hydrophobic can pass through. If it's big, it's hydrophilic, it's polar, it needs something to assist it to pass through, or if we're talking in hormones, the receptor needs to be on the surface. So here in this little image, here's your nice little fat soluble hormone. It can go in, it can act on the receptor on the surface of the nuclear membrane and command the cell to do something. Whereas your water soluble, your polar, your hydrophilic, large hormones will act on a receptor on the cell membrane, commanding a secondary messenger. This is cyclic AMP, then commanding the nucleus to do something. Okay? All right. Diabetes insipidus. Diabetes insipidus has nothing to do with sugar. Okay? Nothing to do with glucose. Diabetes insipidus is a lack of ADH, antidiuretic hormone. So they cannot save water essentially in their body. It leaves in the urine. So the urine should be dilute. All right. The diabetes term comes from the excessive urine. That's where the term comes from. So either they have what's called central diabetes insipidus or nephrogenic. Central diabetes insipidus, the pituitary isn't making it for some reason. They have the receptors in the kidneys. If you were to give them a drug, we could see that. So there's a test, we give vasopressin. If all of a sudden their urine osmolarity increases, we know they have central diabetes. Something up there is wrong. Okay? Nephrogenic, they're missing the receptor. They're making ADH. There's just nowhere for it to act on. Okay? Versus SIADH. Okay, syndrome of inappropriate syndrome of inappropriate ADH. They make too much. This is the opposite now. Now they're holding on to water. They're diluting their electrolytes. So if they consume too much water, they can create abnormalities in their body. Same thing with diabetes insipidus. If they consume too much water, they can wash things out. So they got to monitor their water intake is really what it comes down to. Here in SIADH, their urine would be very concentrate. Okay, so this would be diabetes insipidus on the left. It's very dilute. And SIADH on the right here, very, very concentrated. Typically, SIADH is associated with a paraneoplastic neoplasia or cancer. Okay? So that lung tumor is producing ADH and causing them to overly concentrate their urine and hold on to water, diluting their bloodstream. All right, pituitary. So this is the pituitary, and then up here would be hypothalamus, and we can see they're connected by this stalk called the infundibulum. It's such a fun word, infundibulum. Anyhow. You can lose the whole thing. That's hypopituitarism. So typically you talk about tumors. And what's neat, if you know your anatomy pretty well, passing right under this is the optic chiasma. So the nerves for the eyes is passing right under there, and they cross at the chiasma. So what's neat is when they have a tumor, they'll come in and their complaints will be, I didn't see the car that hit me from the side. I didn't see, the door frame. I keep on running into it. I didn't see, they're not catching things out of the corner of their vision. And the reason is, as that pituitary tumor sits on the optic chiasma and crushes it, it obscures the parts on the inside, which then are the ones that give you your peripheral vision. And so they lose periphery. That's a sign that someone has a pituitary tumor. Okay? Infections, it's kind of rare. It's possible. Definitely it's possible, but it's pretty darn rare. Vascular. These are neat. Post-pregnancy, what's called Sheehan's. So women, when they are pregnant, they increase plasma volume by something like 30%. And when they go to deliver, there can be a sudden loss of volume. The pituitary will self-infarct. It loses its blood flow pressure through here, and it dies. And it's called Sheehan syndrome. So they're not going to release oxytocin anymore. So they won't produce milk. They can't release the milk. Prolactin is non-existent, so they're not even producing the milk. This is part of reasons people will say, like, postpartum depression, or you hear the stories about, like, women saying that's not my baby, and that's from the loss of the hormones. So they need to do hormone replacement after that. Another one that happens that's pretty neat is car accidents. When people don't wear their chest belt. When they don't wear their chest belt and they get into a car accident, their head keeps moving, they whack the dashboard, pituitary just literally snaps off. Just like a pendulum, and gone. So pretty wild. Okay. All right. So pituitary adenomas, that's what they're showing right here. So optic chiasma is passing like right under there. Okay. You can see there's the eyes. There's all kinds of dysfunction that can happen here. Prolactin levels can be altered. They can have secondary amenorrhea. They're not producing, or they're not having menses due to these high levels of prolactin. And then they can even start producing milk without a child. So that's another sign that they have this tumor now. A woman comes in and she's never been pregnant, or she was pregnant years ago, whatever, and all of a sudden she's producing milk. That's a sign. In males, it decreases testosterone production. So suddenly they can have erectile dysfunction, loss of libido, stuff like that. So it does need to be investigated. So I'm going to jump back here for a second. These are the follicles. In here, this is T3, T4 in here. This is your thyroid hormones. Okay? They go hyperactive. And so the problem with this, couple things. One, TED. You may have seen that on TV recently, and that's what's happening here. The eyes are starting to stick out. And the reason is this mucopolysaccharide depositing. It deposits behind the eyes and slowly starts to push the eyes out. So there's like a recent treatment they have for it, and that's just come out like in the past year or so, I think, is when I saw it. The proper name is exophthalmos. There we go. But nowadays they call it TED, or thyroid eye disease. All right, so there's just been a little change in name lately. So it's not just that. Thyroid hormone cranks up your metabolism. It goes through the roof. So weight loss, heat intolerance, tachycardia. They can have heart attacks from this. Okay, they can have a crisis, like an exacerbation of the situation. It just can go out of control. What's neat is that same depositing behind the eyes happens around the base of the tibia, and so it just fattens them up. That's another sign. Okay, they basically won't have ankles. It'll be calf to foot cankles. Okay, for lack of a better term. It's dangerous. So typically what we do, we kill it. That's what we do. We essentially create a secondary hypothyroidism. We give them, so this is imaging using radioactive iodine. Iodine is needed to make T3, T4. So we give them radioactive iodine. It goes into the active thyroid and destroys it locally. So it's super safe to do. So this creates secondary hypothyroidism, and we can treat that. We can give Synthroid. We can regulate it. It's so much easier than worrying about them going into a thyroid crisis and having a heart attack, essentially. Now, primary is Hashimoto's. Hashimoto's autoimmune disease, and it can happen from Graves on its own over time. They can convert to a Hashimoto's because of the destruction of the thyroid. But think the opposite. They tend to gain weight. They have slow metabolism. They have thinning of their hair. Their tongue size increases. Okay, they are not tolerant to the cold. They're always cold feeling. This is Hashimoto's. Hyperparathyroidism. So on the back of your thyroid are the parathyroids. Okay, they're little like rice-sized structures. They're very, very, very small. But they play a role in controlling calcium levels in our bloodstream. Secondary causation, vitamin D deficiency. So either they have renal failure, something's wrong with the liver, it's not in, they're not going out in the sun, it's not in their diet. Any of those could be playing a role. They have, certain diseases, GI tract diseases could play a role in that as well. So hyperparathyroidism, we start to see tons and tons of calcium ripped from the bone. And it's pulled from the bone, and you can see softening of the bone, weakening of the bone. Okay? So it can cause like early onset osteoporosis, essentially. The problem here as well is it can cause tetany. It can cause depolarization spontaneously of nerves. And so they can have basically contraction of their muscles can be extremely painful, and that's what's in this image. The hand is contracted and contorted because the muscles are just in tetany because of the altered calcium levels. Okay? And so what it is calcium stabilizes the sodium channel. If the calcium levels are irregular, sodium will spontaneously enter and cause depolarization of the nerve. Type 1, type 2 diabetes. Basically, the big difference here, when you think type 1, you should think early onset, childhood. Type 2, adulthood. Okay? Type 1, there really isn't a genetic predisposition. Now, what we're learning is like if one kid has it, the siblings should be watched. There is something, but it's not like if your parent has type 1, you're going to have type 1. There's not a genetic connection that we can tell there, okay? Which is pretty interesting. So really, the concept here that we think happens is you catch a cold. It's a virus. Your body misidentifies it or like doesn't read it well because it's so tiny. And your cytotoxic T cells are just cruising around and they see the beta cells in your pancreas. And they're like, oh, it's that virus. Let's go ahead and destroy them. Idiots. It takes out the beta cells. The beta cells are what produce insulin. So you no longer produce insulin. Whereas type 2, typically there is a strong genetic composition. And with type 2, weight gain is a big player here. Diet. Eating sugar does not create diabetes. That's not how it works. Excess calorie intake creates diabetes. Okay? They call it, like in a lot of other countries, they'll call it the sugars. It has no correlation with that. It's diet. Okay? Like our diet sucks here in the U.S. You see little kids drinking soda. It's Coke Zero, judge-free zone. Okay, but I've literally seen one time on my peds clinical, grandmother and mother brought in a toddler and like a 1-year-old, 2-year-old probably, somewhere in there. The toddler's eating McDonald's, fine, whatever, a treat every once in a while, okay? The 1 to 2-year-old had Coke in the bottle, was just drinking Coke. They didn't see a problem with it, okay? They didn't, just the knowledge isn't there to understand that's not good to give to your child. It's excess calories. The sugar is going to rot what teeth they eventually have, and they will be without certain teeth or in pain for quite some time until the adult teeth come in. So it's not appropriate to be giving children stuff like that, and including juice. Fruit was not designed to be juiced. It should not be juiced. Do not drink juice, people. Juice is not healthy. It has just as many sugar calories as a can of Coke. Eating fruit is appropriate. It has fiber in it. That is good for you. And always the analogy I tell students is like, have you ever made orange juice for yourself? How many oranges did it take to make a cup of orange juice? And you'll hear numbers like 6 to 8. Okay. And you can sit and drink that cup of juice, no problem, and you'll probably have a second. That being said, can you sit and eat 6 to 8 oranges in one sitting? You can't, because of the fiber, okay? So you're just consuming excess glucose for no reason. Juice is not good. Do not drink juice. And the worst is like they give it to like the kids in the sippy cup and they're just bathing their teeth in sugar all day. Not appropriate, okay? Insulin. So insulin plays a huge role for us. Glucose is too large and it's polar. How do we know it's polar? Sugar dissolves in water. Keep it easy, people. Okay? It's too large. It's polar. It needs a transport membrane protein. So that's the GLUT4, glucose transporter number 4. Insulin needs to command the cell to operate the GLUT4 transporter. So if you're lacking insulin, you have glucose in your system, you're eating, it's in your bloodstream, but it can't go into the cells, so the cells are starving. So with insulin, we need to be, with type 1 diabetics, they need insulin. With type 2, the problem is it's not responding. The receptors are downplayed, their production might be a little lower, the excess fat is consuming up the insulin. There's quite a few different reasons there. You know, as time goes on, they start to produce less and less insulin, and so over time they gain more and more weight because they're hungry, because cells are starving and other cells are responding, primarily adipose. That's just nature of the beast, okay? Weight loss is one of the biggest things that they can do to protect them. So when you lose a lot of that fat, your insulin effectiveness increases. So right now, you know, the big drug is Ozempic and Wegovy and Zepbound and I don't know what, there's another one. I don't know. Anyways, these are wonder drugs. I get students asking me all the time, what do you think? I think they're wonder drugs because this is a game changer for us as a society. If you lose weight, you decrease the chance of diabetes. Diabetes is the number one causation of end-stage renal disease. So now we're getting rid of a lot of dialysis patients or kidney failure patients. If you lose weight, your cholesterol is going to go down. If you're not eating as much, your cholesterol is going to go down. So if you have high cholesterol, we reduce strokes, we reduce heart attacks. There's that. And then blood pressure. Blood pressure goes down. If you're not overweight, blood pressure will go down. Guaranteed. Okay? So you reduce strokes, you reduce kidney failure, hemorrhages, retinal detachments. I mean, the list goes on and on. Game changer. Game changer. This one drug, by correcting diet, will change the outcome of a lot of patients' long-term lifespan and morbidities that they would have as they got older. So pretty wild when you think about it in that sense. Okay, fatty liver disease will go down. I mean, there's just so much. Theoretically, it could help with alcoholism. I mean, think about it. They need to drink certain volume. If you limit how much they can intake, you're gonna decrease how much they're willing to drink. That being said, they need to stay on the med. And I mean, it's an injection once a week. If you can convince them to do that one injection, I mean, it game changer. And, and if you're sitting there and you're thinking like, well, how does that affect me? I'm not overweight. I don't do this. I'm not, I diet, I exercise. Yeah, you pay taxes. And a lot of your taxes go to pay for hospitals because a lot of patients come in, they don't have coverage or whatever, can't afford it, not here in a tax-paying citizen status. I mean, it costs you money. So if you can reduce the burden on the system, the healthcare system, it affects you as well. Okay. All right. So the problem is with glucose is eventually can migrate into certain cells. So your hemoglobin gets tagged with it. Glucose is solute. So if solute moves into the cell, water follows, cells expand, cells get destroyed. That's it. HbA1c or hemoglobin A1c, this gives us a 90-day picture of your glucose levels. You may eat a meal and spike and come back down, and you check it in the morning and you're great, and yeah, I'm good. My blood glucose level is controlled. But then you go in and your A1c is 13, which is astronomical. Okay. The normal range is 5.6 to 6.4. You're a pre-diabetic. Pre-diabetes should be treated. There's already damage happening to the kidneys. They should be on metformin and so on. 6.5 and up, you're a diabetic. If you're a diabetic, the guidelines, they change from depending on if you have heart issues, high blood pressure, anything like that. But usually under 7.5 is considered controlled diabetes. I've seen people with 13, 14 that walking around normal, but they're causing destruction to their body that they are not aware of because of this simple mechanism here. Solute glucose moving into cells, water following, causing damage. Okay? So it damages all kinds of different areas. So endothelial cells, and so the lining of your blood vessels, and it affects all these different points, increasing clots, reduce nitric oxide production, so we're not dilating like we should, so increased risk of stroke. Kidneys, there's your glomerulus, shoots it. The retina, all these hemorrhages and the white deposits, okay? So retinopathy. It can damage teeth, the enamel, the saliva production is altered. Kidneys, definitely shot. Erectile dysfunction for males, peripheral vascular disease, they lose functioning of blood flow, wound healing is delayed, nerves are damaged, and so they don't feel when they get injured, they get sores that won't close up. My very first surgery that I attended as a student was one of those scenarios. Older lady, didn't give two you-know-what about her glucose levels. She had a sore on the bottom of her foot. Surgeon starts to clean it out. He's cleaning. The next thing you know, you can see the tool he's using to hold the laps, basically the little mini towels, okay, during surgery. It's got a loop on the end, and it's a stick, and you shove the pad through it, and you can clean a wound, debris it. So he's doing that at the bottom of her foot. Next thing you know, you see it poking up the top. The wound was all the way through. I think about that. She had a foot wound all the way through, and she's not even complaining about it. She can't feel it. So he had to just cut the top, and he is passing these pads through to clean the wound. And, he was telling us, he's like, if she continues this in 6 months or so, I'll have to amputate it at the ankle. That's the progression. And he's like, in a year or two, I'll have to take her leg at the knee because of the progression of her not taking care of her wounds, all of that. So diabetes is serious. And that's why I'm saying stuff like Ozempic, okay, you prevent this stuff. I apologize. My two demon children are up here. Metabolic syndrome. So we mentioned this metabolic syndrome, waist size. 40 is not that huge, okay? For males. 35 for women, yeah, it's a little bigger, but it's not horrendously huge. Blood pressure, that's not very high. Triglycerides, that's not very high. Low HDL, especially in men, because estrogen promotes the production of HDL. And fasting blood sugar, 100, that's not very high. This is metabolic syndrome. So this is where, stuff like Ozempic, Wegovy is a game changer here. You get away from this. And so when you do that, you reduce all of these issues. Okay? Huge issues that impact our society. Cushing's. So Cushing's disease, Cushing's syndrome is our secondary. There's their paraneoplastic syndrome. So it's excess cortisol. It can be exogenous. Someone could be taking excess cortisol for some reason. Okay? But typically it's a adrenal adenoma, or in like an adult, you would start to think paraneoplastic. In a child, adrenal adenoma. This is the same kid. That's pretty wild. So they get these excess fat deposits, wound healing is delayed, females can have amenorrhea, they will get these striations, this like thinning of the skin. So that's the abdominal striae, and it'll be like purple bruising, what's called the buffalo hump. It's just this fat deposited on the upper back of the neck. Moon face, their face will round out. So a bunch of different issues there from excess cortisol, osteoporosis, the bones weaken, the bones fracture easily. So something to be mindful of. I had a student when I very first started teaching, and I was teaching AMP1, and I was holding up the femur in lab, and I was like, you don't break the femur. That's pretty tough to break the femur. Like, if someone breaks the femur, they were in a severe motor vehicle accident, like an MVA, a motorcycle, something. Okay, that's not normal. And this little kid in the back raised his hand. He's like, I broke my femur. I was like, were you in a car accident? He's like, no, my brother fell on me off the bed. I was like, whoa. I was like, you take steroids? He's like, yep. I was like, he had Crohn's, and they were being so aggressive to treat the Crohn's with steroids that it weakened his bones that much that he was y'all's age and his femur broke. Okay? It's dangerous. There's a lot of like yellow marrow in there. That's fat. It can go into your bloodstream, and it can occlude the vessels going into your lungs, and you will have basically a heart attack. Your heart will stop. Okay. Addison's is an interesting little bugger. Typically, you talk about it's too much ACTH released. TB can cause this. Okay, so miliary TB, if it's in the bloodstream, that's a death sentence. But ACTH will stimulate melanocytes, okay? And so they'll have a hyperpigmentation that you can see. So they can, like these little lines, for example, discoloration of the gums. And then typically they have hypotension because glucocorticoids and mineralocorticoids are not being produced. So your cortisol and your aldosterone essentially are not being produced. Okay? Pheochromocytoma, my favorite tumor. Okay, I think it's so neat. This is the adrenal gland. That is the tumor, that monster in there. So it's a tumor of the medulla. Basically what happens is they dump norepinephrine, epinephrine for no reason. No reason whatsoever. It just floods their bloodstream. They are sitting on the couch and they will go into full fight or flight on the extreme end. So typically they'll say they have a thunderclap headache. It'll just onset, just massive headache out of nowhere. Due to the constriction of the vessels, they can have heart attacks just sitting there for no reason. They have hypertension, profuse sweating, heart racing, all the fun stuff. It has to be surgically removed. Before they can surgically remove it, what drug do you think they give the patients? What type of drug? What are you thinking? Before they go agitate this little bugger, what are you thinking? If you're thinking a beta blocker, or something to control heart rate, you're correct. The second they agitate this, the norepinephrine the blood pressure will go through the roof, heart rate will go through the roof, so they need to control the heart. So they will load them up on medications like beta blockers to slow the heart so they don't have a heart attack on the table. Okay? Cool?